Next, we will have a discussant, Dr. David Mankoff from the University of Pennsylvania.
Yeah, it's for you to speak into the mic too.
Sorry.
So thank you very much. I want to thank the organizers for giving me the chance to discuss this very interesting paper. I also want to say, as an imaging researcher, I'm delighted to see imaging science get to the podium, and I hope this is an increasing trend. These are my disclosures. None of them are relevant to this particular presentation. I do want to disclose that I'm from the University of Pennsylvania, as were a number of the investigators that contributed to this. However, I was not directly involved in the study. I do want to thank Dr. Winnan, the last presenter, and Dr. Contos, my colleague at Penn, for help with the discussion and providing some slides. So many of you are probably not familiar with radiomics in the audience and don't do that as an everyday practice. So I thought I'd spend just a little bit of time explaining why we do this and what this is. And some of this was covered in the presentation. So the main goal in many ways of screening mammography is to identify cancers, and that remains a very important part of breast cancer screening. However, there is additional information in those images that can, even if there is not a cancer, help identify cancer risk. And this has been best demonstrated for mammographic measures of breast density, which have been shown to be significant predictors of breast cancer risk. But the question, and this was raised in the presentation, can we do better? Can we, in addition to measuring gross measures of density, look at other features of parenchymal, of the breast parenchyma, and try to use that to help us decide whether or not there's risk? And you saw pieces of these images in the last presentation, but here's a way of showing that breasts that are dense are not all of the same complexity, and even in those breasts that are less dense by mammographic measures, you can also see significant differences in complexity. And so this is what radiomics is all about in many ways, is to identify these parenchymal features in a way that provides more information and will hopefully be predictive and as was questioned, and so associate with the biology. So let's start by understanding this process in the context of other omics measures that you're used to. And I suspect most folks here are used to the identification of gene expression from a piece of tissue obtained by tumor biopsy, using the pioneering work, some of which was presented earlier in this meeting, on gene expression arrays, more modernly RNA-seq. You can think of radiomics in analogy to that. So with radiomics, we're going a step or two further in that we're not only representing gene expression in this case, but we're representing the integrated structure of the proteins and other substances that come from this process and represent integrated tissue architecture. So this is perhaps a very high level reflection of what happens in genes and gene products and proteins. And it also represents environmental factors such as diet and certain exposures that may influence breast architecture. So in many ways, this gives a complementary window to some of the biologic factors that have been identified and came up in the question and answer period. And as you saw, you can go back and extract these features, much as you would cluster genes, and you can find a cluster association between these features and certain factors that indicate breast cancer risk, again, as you saw in the prior presentation. So this is an illustration, courtesy of Dr. Contos, that talks to you a little bit about how radiomics works. Okay? I'm not going to ask you to go back and derive those equations. Maybe there's some people that want to after a cup of coffee or two, but I thought this might be illustrative of the types of things we look at. These are just four of the features that often end up in this parenchymal texture analysis. One is skewness. You can think about this as asymmetry in the histogram of breast density or measures if you want to think about that. And you can see examples of a dense region of interest and a fatty region of interest. Now, the others are a little harder to understand, and I have the equations up there for completeness, but you can have elements of fine texture, which I think you can see in the coarseness area, and also more coarse or more blocky type of texture that you see there as well. You have contrast and energy, where you see the distinction between the more dense elements in the background. And then in something I won't try to explain, because I don't completely understand it myself, there are well-known equations for fractal dimension that describe underlying structures to images that are universal, whether you're looking at a piece of tissue or a variety of other things occurring in nature. See if I can get my slide to advance here. Yep, I've been pressing. Thank you. All right. So does radiomics help cancer risk? And in an earlier paper that came from the same group published by Dr. Kontos in Radiology, there was again an identification of these distinct clustered subtypes of radiomics that had an association with risk that was statistically significant. There have also been a number of other studies along this line. I want to highlight studies that was published about the same time coming from the University of Chicago and Mary Ellen Geiger's lab there that looked at this in a slightly different way, using in mammograms an analysis of a suspected lesion as well as the analysis of parenchymal density in the contralateral breast, both of which provided some element of the risk that this was a cancer, and used this risk measure not only to predict risk, but really to improve the accuracy of diagnosis, again, the primary role of mammography. Now, as we return back to the study from Dr. Kontos, the numbers were reasonable in that size for an early study, but relatively small. This now brings us to the current study that you just heard about. So this is the subsequent study that was just presented, and you can see that the numbers here are quite a bit larger. The number of sets coming from a similar set of institutions got into about the 30,000 range, and we're up to now a total of 3,000 patients drawn from a separate population that are cases and matched controls. And again, one of the other distinctions of this approach is there was a reasonably diverse group of patients with a modest fraction of black patients in an overall cohort that was large. So you saw this in the presentation, and I thought I would explain it a little bit more. There is a hierarchical clustering approach that I think many folks will be used to from the approaches that are taken in genomics and other forms of omics. And that was done here, and it was done reproducibly between the training set and the validation set, which is reassuring to show that you're getting consistent measures across patients. Now, the principal component analysis is actually something that is older than AI and radiomics in some sense, and is a technique that has been used to describe, in simpler terms, the complexity of a large matrix. And it's a technique that's used widely in physics and engineering and now has been adapted in the AI world. And part of the reason one takes on this type of approach in this case is that it does a better quantitative job of describing the kind of information that you're pulling out from the radiomic analysis. And in particular, one of the distinctions here is that prediction went into a model which was used quantitatively to explore whether or not that increased the accuracy of prediction of a number of important outcomes. And so that was one of the reasons for moving this process to a more principal components analysis, which provided, not surprisingly, the best predictive value. So what happened here? After establishing that these were reproducible phenotypes and getting consistent data between a training and validation study, the authors went on to compare two models in predicting outcomes. One of those models is BIRADS, the category of both risk and density in the breast image by standard lexicons, body mass index, and age. To that, they added the information they got from the radiomics analysis represented as quantitative principal components, as was shown on the last slide. They applied these to three different outcomes. One was risk, and that was the risk assessed by follow-up about whether or not the patients entered into this cohort had a diagnosis of breast cancer at some point. There was also a false negative component to this, that was anybody that had an interval cancer detected by any means over the next year. So in some sense, the imaging that they were analysis was a false negative and missed a cancer. There's also something called interval cancers or maskings, and these are actually symptomatic interval cancers. And in essence, these were masses that were probably there at the time of the image, but might have been masked by associated density or other features on the image. One of the things I want to emphasize in this presentation compared to a lot of what's been done in the field before is this measured diagnostic performance using ROC curves in estimating these risks. That's a much more statistically demanding test, and a much more a demanding test in general than simply looking for associations. So what did we find? And you've seen these before. What we found is, unfortunately, in the overall population, there really wasn't much of an impact of the radiomic features on the overall prediction model of risk. And in fact, in the white population, that was repeated. But interestingly enough, in the population of black women, there were some distinct radiomic features represented by the analysis that appear to improve the prediction of risk. Those are not, those confidence intervals still overlap, so we haven't quite hit statistical significance, but that's a noticeable effect that hints there could be some important information there. Very interesting that when we looked at false negatives and symptomatic interval cancers, we again saw that this prediction of risk actually added something to the conventional model, almost getting to the point of separating over 95% confidence intervals. So some strong hints that this particular analysis could potentially identify those patients that are at risk for having had a cancer missed at the time that the imaging was performed. So what are the results and implications of this process? Number one of the questions that comes up often about this AI and radiomics work is it reproducible? And here is an example of a group that did this in a small cohort, went to a much larger cohort, and really did find consistent approaches to a couple of ways of analyzing that radiomic information. And very interesting, this identified a phenotype for black women that was distinct from the rest of the cohort that could actually potentially be useful in helping to guide therapy in the future. Radiomic phenotype did not significantly improve risk prediction in the full cohort, but there was a non-significant trend towards improved prediction in the black women, and it was also some hints that this would work well at identifying potential false negatives, and particularly symptomatic interval cancers or masking. So it raises the question overall, are we at the point where we can start to begin thinking about how radiomics might guide individual approaches to breast cancer screening and diagnosis? And so in my last slide, I'd like to flesh this out a little bit and have some questions to think about considering for, I think, this very interesting trial. And number one is, how could we use radiomics with these types of results to guide cancer screening? And in particular, if what this is doing the best at is identifying patients at risk for missing a cancer, could we think about using this for alternative modalities? We've heard about this a little bit in this meeting, or more frequent interval imaging to make sure that we don't miss those cancers that may be more likely to be present. It's interesting to note that there were phenotypic differences in radiomics for black women versus white women, and also that there were phenotypic differences that were associated with predicting symptomatic interval cancers. I don't know that we know yet that those are the same phenotypic differences, but it'd be very interesting to go back and explore that more to identify whether there are some of these factors that are associated with race that might help guide treatment as well. Also, what do these radiomic features mean? If we're missing these cancers, is these really radiomic features about the background that might mask a mass that may be lurking in the image? Or are these biologic factors associated with higher cancer risk, or are they both? Can the addition of radiomic data improve the diagnostic accuracy of mammography interpretation, as you saw from the University of Chicago paper? And importantly, these are mammograms, and the world is increasingly moving towards digital breast tomosynthesis. So does this apply to digital breast tomosynthesis? Does it apply to MRI for those patients that undergo screening MRI? So in conclusion, I want to congratulate the team on what is a really very exciting glimpse of what may happen in the future of imaging and data science, and encourage them and others working in this area to think about the next step in these studies, not only to continue to define and develop this approach, but to continue to understand the associated imaging features and their associated biology as we think about where to apply these very exciting and potentially powerful tools, but with much to be learned still. And I thank you again for the chance to discuss this paper.
Thank you, Dr. Mankoff.